Hey team, this afternoon we're going to talk about lung ultrasound. Now, generally we consider air is the enemy of ultrasound, but when it comes to lung ultrasound, we can rely on the artifacts to look for different findings that represent pathology. Let's start this one out with a case. A patient comes into your emergency department or into your clinic, and she's a 65-year-old female. She comes in with shortness of breath that's been getting worse over the past few weeks. She doesn't have a fever, she doesn't have chest pain, she doesn't have cough. You take it further, she doesn't have any lower extremity swelling, she hasn't been out of the country recently. She does have a history of hypertension and breast cancer. As you do your physical exam, you reveal that she is afebrile, but she has an increased respiratory rate to 30. She's a little bit tachycardic, and she is satting only 91% on room air. She's well appearing, she's no acute distress, but she does appear to have some labored respirations. When you examine her lungs, you find that she has decreased breath sounds on the left. So what do you want to do to work this patient up? You're going to order some labs, an EKG, because you always have to think about the heart in your dyspneic patients. You're going to do a chest x-ray, but can you do a bedside ultrasound? Certainly. So ultrasound in the patient with shortness of breath. Ultrasound is great for looking at the pleura, the lung parenchyma, the diaphragm, the pleural space, and of course, the heart in patients with dyspnea. When it comes to choosing your ultrasound machine, so thoracic ultrasound was first developed with older probes. So these older probes were not as nice as the probes we have now. Right now we have harmonics, we have volume averaging that give you these really nice, beautiful images, but they can help take away the artifacts that led to thoracic ultrasound. So you want to make sure that you are taking away your harmonics, your volume averaging, or if you're looking at an ultrasound machine, choose a preset that is designed for lung imaging. So oftentimes on ultrasound machines, you'll have a thoracic preset. So choose your thoracic preset, and that will give you optimum viewing for lung imaging. Next, we want to choose which ultrasound probe we're going to use. So your linear probe, we said it's a high frequency probe, and it's great for near field imaging and superficial structures. So looking at your pleural line, maybe anterior pleural fluid collections or anterior and superior lung pathology. Now, if you want to identify posterior effusions or really look at the lung parenchyma, your phased array probe might be your next choice. It has near field imaging. It's pretty limited, but it does have great depth. And then we come back to our jack of all trades probe, our curvilinear probe. So the near field is curved and wide. You can get adequate superficial resolution and great depth. So you can use this probe for both applications if you're looking superiorly and anteriorly for lung sliding, or if you're looking deep into the lung parenchyma. To truly assess for B-lines, a finding we'll talk about in a few minutes, you'll want a low frequency probe that can go to a depth of 18 centimeters. So for a pulmonary scan, we want to divide the chest into different zones. Our zones are delineated by our anterior and posterior axillary lines, and we want to scan through each zone. So where would you want the scan? Generally, you might want to scan in the different places you would place a stethoscope. Pulmonary scanning requires understanding and interpretation of artifacts. These artifacts are not real, however, they may present real pathology. Remember some basic physics, a little more simple than our ultrasound physics. Remember that unloculated pleural air will rise and unloculated pleural fluid will sink. Now, for all of you Game of Thrones fans, remember A Song of Ice and Fire? Well, in ultrasound, we have a song of air and water. And those are really what we're looking at when it comes to thoracic ultrasound. What are the pathologies that we think of in regards to lung ultrasound? And are those primarily air issues, or are they primarily water or fluid issues? Let's think about this. A pneumothorax, that's an air issue. COPD with blebs, that's an air issue. CHF, that's a water issue. Pulmonary effusion or pleural effusion, air issue. pneumonia, water issue. So air and water are going to create their own artifacts, and we have to put that into the context of our patient to help determine what's going on. The first thing we're going to talk about are our air artifacts, and we're going to start with A-lines. So these are present in normal or dry lungs. A-lines are a reverberation artifact, going back to our ultrasound physics lecture. This is a reverberation artifact that occurs when the ultrasound beam is reflected off of a highly reflective surface, or the lung pleura. The first horizontal line is the true image. The beam is then reflected again off the transducer, and since it takes twice as long, a second line equidistant to the first appears, and so on and so on. This is normally present in dry lungs. It's a horizontal reverberation artifact. It might also be present in a pneumothorax. So here's what your A-lines look like. We can see those nice, bright, horizontal, evenly spaced lines. The arrows are pointing at them to make it a little bit easier. So those are your A-lines. And here's another example of A-lines here. The next aspect that we want to look at in thoracic ultrasound is something we call pleural sliding. Pleural sliding is a shimmering artifact when the parietal pleura and the visceral pleura slide on top of one another. Remember that your parietal pleura attaches to your intothoracic cage and your visceral pleura is attached to expanded lung. Visceral pleura slides underneath the parietal pleura and causes this shimmery artifact, almost like ants marching. You might also see a very small vertical bright line coming down just a few millimeters from the pleura, and this is your comet tail artifact. It is a type of ring down artifact that we see. It's similar in appearance to a beeline, which we'll get to in a few minutes, but it's a comet tail only coming down just a few little millimeters. And this indicates that the lung is fully expanded, that the parietal pleura and the visceral pleura are not attached, but they are approximated and sliding on top of one another. When we look for pleural sliding, we want to make sure that we have our probe marker oriented in the sagittal axis with the probe marker pointing towards the ribs or to the head. We want to see ribs on either side of the screen and then looking between those ribs for the pleural line right there. We can note the pleural sliding. It's a shimmery artifact right there. Note a few comet tail artifacts just coming down off of that pleural line. This is a vertical artifact. This is also what's called the bat sign, looking at the ribs and then the pleural line between them. We can use M mode also when evaluating pleural sliding. So get your nice B mode image, then place your M mode line over the pleura and look to see if you see a discrepancy in the soft tissue and then in the movement in the pleura. We call this a seashore sign. You should be able to see right at that arrow where you have lung sliding, and then on top of that you have just the soft tissue. So a better depiction in my book of the seashore sign. So just note here we have the waves and then kind of the sandy beach, which indicates a fully expanded lung if you're looking at lung sliding with M mode. If you have lack of pleural sliding, we need to go through our differential about what could be causing that lack of or decreased pleural sliding. The true positive that we're always worried about is a pneumothorax. However, there are several things that can cause a false positive for lung sliding. That would be a poor respiratory effort, mechanical ventilation, main stem intubation, or even apnea. So when we're looking at the lungs and looking for lung sliding here, if all of a sudden we have a collapse of that lung and the visceral and the parietal pleura become separated by air, then we're going to see no lung sliding. So if you look closely here, we see our two rib shadows and we see our nice bright pleural line. And if we look really closely, we do not see that lung sliding. So I do not see that nice shimmery lung sliding artifact that we want to see. So this is no lung sliding, so no pleural sliding. And if we take it a step further and look in M mode, we don't see that nice sandy appearance that indicates the fully inflated lung. So it looks like a barcode all the way down. And that's known as the barcode or stratosphere sign. The one thing that is specific, 100% specific for a pneumothorax, is something we call the lung point sign. So if you look really closely at the screen here, you'll see lung sliding on the left side of the screen along the pleural line, but just about the center of the image to the right, you have no lung sliding. And you can actually see a sharp point in which you have lung sliding to no lung sliding, and that is your lead point of a pneumothorax. So if you can imagine your lung has your visceral and parietal pleura at that exact point have now become separated, and you have a pneumothorax. The next lung pathology we really want to focus on are the lung pathologies, or what we see that are more water-based. So we want to look at interstitial fluid in the lungs. Interstitial fluid in alveoli produces a lung artifact known as B lines. So these B lines are not present in dry lungs. However, as your interstitial fluid increases, you'll start to see more and more B lines. We see B lines in pulmonary edema, CHF exacerbations. So B lines originate from the pleural line. They are prominent and deep lines. They will go all the way down to 18 centimeters, and they almost look like a lightsaber just piercing vertically through the lung. B lines also move with respiration. It's important to remember that an isolated B line is totally normal. However, more than 3 is pathologic. The more B lines, the more pathology related to the disease process. If we're looking for B lines and we see less than 3 B lines, that's fine. We don't see any pathology. If we are looking for B lines and we see greater than or equal to 3 that are few in number, intermittently present, that might be indicative of mild pulmonary edema. And so on. We have moderate B lines, and then severe, we'll have just complete coalescence of B lines that cause a curtain coming down. We will see B lines with a lung contusion. Just remember, if the patient has a history of trauma, we'll see B lines in ARDS, volume overload, and pneumonia. So an example of B lines right here. Unfortunately, in this particular image, we used a linear probe, so we're only seeing them go down about 5 to 6 centimeters, but if we were to use a curvilinear probe, we would see the B lines go all the way down to 18 centimeters. So we can see this nice pleural sliding, and then we'll see this bright white, almost lightsaber come off vertically from the pleural line and pierce all the way down to the bottom of the screen. We can also see that we have a little curtain of B lines over to the left, indicating your B lines are now coalescing. And here's another example of B lines. So pay close attention to the number of B lines, the deep comet tails, and this as they move. So you can see that the B lines are moving with inspiration, and we're seeing quite a few, definitely more than 3. They look like they're starting to coalesce, and so I'm pretty worried that this patient has a moderate to severe amount of interstitial fluid in their lungs. So are you treating them for a CHF exacerbation? What can we do to help improve their breathing here? Next, we want to look for consolidations. So this is pneumonia in a girl, and we can see pneumonia on ultrasound. I want you to note the consolidated lung with the small surrounding effusion. Now, if you look here up at the top of the screen, we're on the patient's right. We're in her right axilla. So on the far right of the screen, we'll have the patient's liver. We have the diaphragm, which is a bright white line above it. And then on the left side of the screen, it looks like we have another area that looks similar to the liver in appearance, and that is fluid-filled lung. It's become so filled with fluid, or in this case pus, that it has actually started to condense. We're seeing some bright white lines or little spots right in the middle of that area, which are air bronchograms. So this is the shred sign, and this appears when the border of aerated lung and consolidated lung is not sharp. The shred sign indicates a non-translobar consolidation. So just above those little bright white bubbles, if you will, we have consolidated lung that looks a lot like the liver, and then we're starting to see the aerated lung. So consolidated lung appears solid and hypoechoic, almost like a liver. Consolidated lung is rich in water or perhaps pus. So note the irregular border of the interface. It's tattered and almost looks like a rat has come along and eaten the edges. So that's the shred sign. So this is the same patient. We're seeing a little bit of a pleural effusion, which is black fluid surrounding the lungs. We're seeing consolidated lung and those air bronchograms. Now we're seeing pulmonary consolidation. So note how the lung appears to be solid. Like, it would be really hard to tell if this were a liver or a lung right here. Consider the amount of fluid that must be present in this lung. It must be a ton of fluid. It has the same echogenicity as the liver or spleen, so it's called hepatization of the lung here. This is a translobar consolidation, and we can also see those air bronchograms, so those little white bubbles right in the middle of that lung. One thing we also see is the spine sign right here, which indicates that there's a pleural effusion as well. So now we're going to talk about pleural fluid. Ultrasound is sensitive for pleural fluid, but it cannot determine what type of fluid it is. It cannot determine whether it's bloody fluid or non-bloody fluid. It may show debris and septations or some solid material, and it might help identify fluid versus a consolidation, but it can't tell you what it's from. So for pleural fluid, we want to use the liver and spleen as our windows, and we want to look above the diaphragm. We want to look for the spine sign, so looking for the spine above the diaphragm, and look mid to posterior axillary line. So with the pleural effusion, the ultrasound beams will travel through the fluid, allowing you to see the vertebral bodies. Now, if you have a lung that's full of air without any pleural effusion, remember that air is actually the enemy of ultrasound, and so those ultrasound beams are not going to be able to travel through that lung-filled or that air-filled lung and will not be able to make it to the vertebral bodies. So if you're seeing the spine above the diaphragm, you have pleural fluid. So this is an example right here of pleural fluid. It's hard to tell whether we're on the patient's right or left, but we're seeing diaphragm as that bright white line and splenic liver, and then above the diaphragm we are seeing just this nice large black area or anechoic area that is fluid. So that's a nice large pleural effusion. This is a view of the spine sign that we talked about. So this is the patient's right, and if we were to slide our probe down just a little bit, we would see the patient's diaphragm. We can see it kind of coming in and out at the very right of the screen. And if you look at the bottom of the screen, that bright white line, that's the vertebral body, that's the spine. So we're seeing that well above the diaphragm, indicating that there is a pleural effusion. And now we can see this nice black area of fluid, and we see this little triangle right here, and that's just this super heavy condensed lung floating in the middle of all of this fluid. And this one is a really interesting one. So here we're on the patient's left. We have a large pleural effusion. We actually see the lung right here. It kind of looks like a fish tail, if you will, or a little mermaid tail swimming around in all of that fluid. And now we can see the heart below. So if you just watch to the end of the clip, we see a lot of pleural fluid. We see lung that's consolidated that almost looks like a fishtail, and we're seeing the heart at the very bottom, the left ventricle here. So going back to our patient, Mrs. B, you're waiting on your portable chest x-ray, so you wheel the ultrasound machine over to the patient and obtain these images. So what are we seeing here? We're looking above the diaphragm, we're seeing this spine sign, we're seeing a lot of anechoic area, and then a little tail of something that's flapping around in the fluid. So Mrs. B has a rather large pleural effusion. The x-ray confirms your large pleural effusion, so then you go back to your ultrasound and do an ultrasound guided thoracentesis, send the fluid off to cytology, and admit the patient. So remember, ultrasound is great at looking for artifacts in the lungs, and these artifacts represent pathology. We have the air artifacts looking for A lines. We want to look for lung sliding. We want to look for a lung point sign if you're suspicious for a pneumothorax. And then we go to our water pathology, if you will. We're looking for B lines, we are looking for a pleural effusion, and we're looking for consolidations. Hope you all enjoyed this, and please email me with any questions. Thank you.